So I'm going to primarily, Grace and I are going to tag team. I'm primarily going to focus on Omicron and some on the pediatric vaccines, and then she's really going to delve into the safety issues that she's dealt with as the chair of ACIP. So these are my disclosures. And I just want to start off by making a very strong statement on behalf of the American Academy of Pediatrics that has said that they recommend COVID-19 vaccination of children and adolescents 5 years in age of and older who do not have contraindications for using COVID-19 vaccine, and just following the FDA and CDC recommendations. And this slide really is just the usual overview, but you can see where we are in the pandemic. We have over 50 million cases recorded in the US at this point, almost 2 years into the pandemic, and sadly, over 80,000 people have died already in the country. We have, we're seeing I don't know if this is a fourth wave or fifth wave. We're not quite sure. The last wave really didn't go away, but we're seeing an increase here. And you can see down in the bottom right that the number of just pediatric cases, this comes from the AAP website, that we're not dropping. In fact, we're going back up after the current surge. And the concern here, of course, is that we're heading into winter time. So we don't think these numbers are really going to drop much at this point. If you look here at this slide, this again is a lot of this is the AAP that's been able to compile this data, really understanding what's been going on with children over time. And you see that children are making up more and more cases overall in the US. And the Delta surge seems to have really taken a big hit here in the US. And we're now our children represent about 1%, a quarter of all cases in the US. And the cumulative number of cases is about 1% of all kids documented. If you look at the number of children, over 7 million cases as a proportion of the total population of children in the United States. So clearly not what we heard at the beginning of the pandemic, which is that children don't get infected or get sick. Now, if you look overall at the population of children in the US, they make up over 22% of the population. You can see here cumulatively, just about 20% of all children 5 to 11 have received a vaccine, at least one dose of vaccine here. You can see, unfortunately, cumulatively looks great. Unfortunately, it looks like we're slowing down. I don't know if that's because of the holidays, but we do see that the initial vaccine was for 5 to 11-year-olds was approved the first week of November. There was a big increase, and now we're seeming to flatten out. And you'll hear a little bit more about this later, but basically in 12 to 17-year-olds, about 60% have received at least one dose. So we're doing a little better there, but we've had a lot more time since May to vaccinate children 12 to 17 years of age. So I want to spend most of my time talking about Omicron because we don't know a lot, but we do have some information which we think might be helpful. So the timeline is that the virus was first detected in specimens collected on November 11th in Botswana and November 14th in South Africa. And there's some spin that perhaps there was a connection with the Netherlands, people visiting. And so again, everyone is kind of pointing fingers, but we really want to get away from location-based variants because they're going to pop up everywhere. But very quickly thereafter, the World Health Organization really got involved and called this a variant of concern. And I'll show you why in a second. Our first case in the United States showed up that we detected on December 1st, but now we are seeing cases in over half of the US states and in over 80 countries in the world. So it's moving quite rapidly. This is a slide that I think was worrisome to the World Health Organization. This is a site that I've talked about to you before. It's called nextstrain.org. I started following this website back in April of last year when I was teaching a class on epidemiology of infectious diseases. It's a great website where you can actually track the evolution of a virus. And there at the bottom, you see all the different viruses. This is really focused only on Africa, but the strains reported from Africa. And you see up in the green and blue, the variants, the Delta variants primarily. And then you see this red spot up at the top. That is the Omicron variant. And what this shows you is that red line going up doesn't mean that it was traveling along. It means that it is related, that it is not related to the others. It just showed up probably sometime in fall, and it is complete, its mutations are completely different from the mutations that we're seeing evolve naturally over time. So that is very worrisome because there are a lot of implications, which I'll go over. Now, the characteristics of this virus from a virologic standpoint is, as we said, there have been many cases around the world with a potential from a virologic standpoint, understanding where the mutations are, of increased transmissibility. There are just in the spike gene alone, this is a picture of looking down at the spike gene, the spike protein, is that the spike gene itself has 30 mutations in it, 15 of those in the receptor binding domain. And so this could result in potential reductions in efficacy of some antibody treatments and in neutralization. And I'll show you in a bit what that means based on studies that we've already had available to us. Now, the Omicron mutations in the receptor binding domain and N-terminal domain are really the ones that are associated with resistance to neutralizing antibodies and monoclonal antibody treatments. A few of the most concerning ones are associated with more efficient cell entry. Some other ones, one other one is associated with immune evasion. In addition, there are 2 mutations in the nucleocapsid protein, not the spike, that are associated with increased infectivity. And because of and you saw the line there, because this is so different from the others, did not evolve naturally from other people. It appears that this virus may have just mutated spontaneously from an individual who had continued inability to suppress the virus, and then it mutated within that person. And so we don't really know how this virus will interact with others or with our immunity, because it really evolved spontaneously apart from all the others. Now, what we have seen, and I'm just summarizing here a number of the papers that have been put out in the last month since we found out about this virus, is that this virus is more likely to be more transmissible than the original SARS-CoV-2. We know that's probably true. It does appear that this says that the Omicron may spread as fast as Delta, but there is some indication from some small papers that it may be 2 to 3 times more likely to be infectious compared to Delta. So if you think about how the original virus mutated to Delta, and that was 50% more transmissible, this is probably 50% more transmissible even so than Delta. And vaccinated people with breakthrough or people infected without symptoms can spread to others. What we really don't know yet is whether or not the virus causes more severe illness or death. We just don't have enough cases to understand that. But we do think, in summary, and I'll show you the data, that vaccines can be protective. And we're still determining issues around monoclonals and other drugs. This is a slide looking at what's happening in the UK. The United Kingdom on Wednesday recorded the highest number of COVID cases that they have ever had since the beginning of the pandemic, over 78,000 cases. And that's despite the fact that they are heavily vaccinated in their country. And so you can see here the Delta variants there, and this is the rise or doubling time of the virus. And you see that Omicron doubles much faster. So we think the doubling time of Omicron is 2 to 3 days. So that's a really fast doubling time. And we know the doubling times change as the pool of susceptibles change. So it may be that the doubling time slows down, but right now it's moving very, very quickly. This map shows you where we were just 2 weeks ago and where the cases had been reported. Now, remember, that was just because people weren't looking, obviously, but you see as of yesterday how many, all these dots indicated places where the virus has been reported. And you can see that the majority of the cases, this is global, but we're seeing them in every continent so far around the world. So it is moving quickly. We think that the UK will hit their peak probably sometime this next week. And we think that the US will probably hit some kind of a surge in early January. This shows you an overall smoothed out version of the different variants. You can see that Delta is still predominant in most of the world, but you see that Omicron is starting to take off in Africa, but also will be starting to become important in Europe and other parts of the world. Now, specific cases around clinical findings is that, as we said, we heard of a doubling time of 3.4 days in one province in South Africa, but I've heard in other papers, again, doubling times of 2 days or so. In Norway, for example, there was a Christmas party outbreak with an attack rate of over 70%, and most of those people were vaccinated with 2 doses. Fortunately, the disease has been not mild so far. And these are cases reported in the US so far. 37 jurisdictions have reported at least one case. This was as of yesterday, so obviously that number is going to change over time. MMWR just put out a summary of the first 43 cases identified in 22 states. A third of those had international travel history, also domestic travel, large public events, and household transmission. About 80% were fully vaccinated, and a third had a booster dose, although a third of those with a booster had only had their booster within 2 weeks. But still, we think that this doesn't bode well for full vaccination and potentially even boosting, and 14% had previous infection. What is CDC doing? Well, you'll hear safety from Dr. Lee, but monitoring genomic surveillance and vaccine breakthrough is critical. We're lucky here that we are running a CDC-funded respiratory virus transmission network that we're hoping with IRB approval to start in January. We've been pushing the paperwork as quickly as possible, but we're going to hope to start doing surveillance here at Stanford for not only COVID, but also for flu and other viruses. Working to answer important scientific questions, vaccine effectiveness, and then drafting recommendations related to travel and prevention strategies. Genomic surveillance is critical. We need to understand where the virus is and what it might be doing relative to, say, Delta. And CDC currently estimates that if the variant is currently circulating at 0.1% frequency, it could be detected in national surveillance. So that's good news. And there will be enhanced surveillance looking just for this virus as well as for the previous Delta, and then expanded voluntary airport-based surveillance programs at key airports, including San Francisco Airport. Now, this shows you where we are as of yesterday, December 11th, so a few days ago. So you can see that Delta is still the major variant of concern, and Omicron is at 2.9%. But we fully anticipate that it will be taking over given how transmissible it really is. Now, this is an important slide because it summarizes a number of papers around neutralization. What we want to know, obviously, is does our current immunity, vaccine-induced immunity, protect us from Omicron infection? And 15 preliminary studies using sera from both pseudoviruses and live viruses from individuals who've been vaccinated show a 15 to 127-fold reduction in neutralizing capacity compared with wild type virus, and an 11-fold reduction compared with Delta. And in addition, what we want to know is not only reduction, but do we reach that limit of detection? We know that about 100, we need about a titer of about 100 units of neutralizing antibody to prevent infection, or at least severe infection. And it looks like the neutralization of Omicron is below that limit for most individuals who receive only 2 doses of mRNA or 1 dose of Janssen vaccine. And the neutralization of Omicron is above the limit of detection. So you do get some good immunity, and I'll show you a slide in a bit, in many vaccinated people who have gotten 2 doses plus a booster or who were previously infected. Now, what's unfortunate is the Janssen vaccine data, I just saw an early preprint, the 1 dose does not have any detectable neutralizing antibody to Omicron at all. So, and again, these are laboratory assays, so we don't know what this means clinically yet, but we are concerned enough that we are hoping that boosters will be another help and tool against this new variant. Now, the Pfizer vaccine in South Africa demonstrated 70% protection against hospitalization and 33% against infection. But again, remember, the goal for vaccination was primarily initially to prevent hospitalization and death. So that's good. But we are going to see transmission if it only has 33% protection against infection during the Omicron wave. It was reduced compared with Delta, which showed 93% protection against hospitalization and 80% protection against infection. But booster vaccination has not yet been evaluated in South Africa. The risk of hospitalization among adults with COVID-19 was 29% lower for Omicron variants compared to the ancestral lineage. So that's good news. What we're saying here, at least initially, it appears that infection does not lead to hospitalization as often. Unfortunately, there's some incomplete data. We haven't seen the full data on kids, and it looks like children may be 20% less likely to be infected with this virus. This again is top line data. We haven't seen the paper, but it appears that children who are infected, at least in South Africa, may have a 50% more risk of being hospitalized if they are infected. So we don't really understand that because there may be some incidental infections in that group. So for example, some of those 50% were kids who were hospitalized for other reasons. So we need more data. That has not been available to us yet. This is a slide showing vaccine effectiveness among Delta and Omicron variants in the United Kingdom. It's the only data we really have around this. And you can see here, Delta in the squares and Omicron in the circles. And you can see that within 2 to 9 weeks after vaccination with your second dose, you have really good titers, vaccine effectiveness, and then over time you drop for both of them, but you see that the drop in waning in immunity is much more impactful for the Omicron variant here in the circles, down to 35% of effectiveness at about 6 months out, compared to about 64% effectiveness for against Delta. But the booster does get you back up to 76% vaccine effectiveness compared to 93% for Delta. So boosters are still working reasonably well after your second dose. The World Health Organization has also have preliminary evidence that there is an increased reinfection risk, and this makes sense because with so many mutations, the virus is able to provide some immune escape. So there is probably more reinfection with Omicron. So we have to see more about that, and I'll show you where they got the data. So the top slide there shows you the 3 surges of primary infections in South Africa. Here's one, the different times of over the course of the pandemic. These are the cumulative number of people at risk for reinfection. And you see here that with Delta, we saw some reinfections, but you see that there are more reinfections with Omicron during the Omicron period here. And so we're concerned that there may be more immune evasion. However, the chair of the South African Medical Association, where they've had the most experience so far with this virus, told the BBC that symptoms were unusual, different from the Delta variant, focusing primarily on fatigue and body aches, but mostly mild. But again, we don't have hundreds of thousands of cases yet. Fortunately, we only have hundreds of cases around the world. We don't really know if this reduction in severity is going to be important. So for example, if the virus is twice as transmissible, but half as severe, you still wind up with the same amount of hospitalizations and deaths compared to Delta, because those two cancel each other out. Now, what about boosters and second generation vaccines? Well, of course, the companies are looking. Moderna's testing a higher booster dosage of its existing vaccine and evaluating 2 multivalent vaccines for Beta and Delta variants against Omicron, and they're developing an Omicron specific vaccine. Pfizer's also evaluating Alpha, Beta, and Delta boosters and developing an Omicron specific one, but there are no studies shared with us to date. So this is I guess, an attempt at humor. Everybody's really worried. What are we going to do? Barricade everything, don't let it in. And meanwhile, it's sitting in our living room already. So I think we need to be very careful, especially over the holiday season. What do we need to do? We need to get vaccinated. I can't emphasize that. Grace and I just can't say that enough. Get boosted. Absolutely get boosted. Get prepared to act more cautiously. Although I know people are burned out, we really do need to be careful because we don't know if this is the virus that we wanted, that is more transmissible and less severe, which might mean another cold virus, which would be great, but we don't know that yet. Follow the news and science as it evolves. I know it's tough, but Grace and I try to keep up with everything and let you all know as we find out. And of course, CDC has updated its booster guidance, as you probably all know now. All adults ages 18 and up should get a booster. And we just heard this week that 16-year-olds as well and above can get a booster as well. The President Biden 2 weeks ago announced new actions around Delta and Omicron, including boosters, vaccinations, free at-home testing, public health protocols, rapid response teams, et cetera. So we are working very hard to do this. We vaccination is recommended for everyone aged greater than 5. Boosters are recommended for everyone over 18. And again, I just mentioned 16 and older as well for the Pfizer. And increased use of masking, improved ventilation, testing, and adherence to guidance on quarantine and isolation. We don't want to forget that we still have a Delta wave. So in UK, with their highest numbers of cases ever, most of it is still Delta, but now they're going to see Delta and superimpose Omicron. And then, of course, we still have RSV and flu to deal with. So currently authorized vaccines offer protection against known variants. We are monitoring real world effectiveness, but we still need to wait for that to happen, monitor emerging variants, and we will continue to notify people about that. Now, let me just spend the next 5 minutes talking about the pediatric vaccines. So this time last year, as Grace well remembers, on December 11th to 12th of last year, we had a major ray of hope when there was a discussion about the Pfizer BioNTech vaccine with the stunning data around 95% efficacy, then 94% efficacy, and then the first COVID-19 vaccines, and that's the first person there to receive the vaccine at Mount Sinai. And then just a week later, discussion of Moderna and a vote as well. But since that time, we have delivered over 500 million doses of vaccine, and almost 500 million doses have been administered in the US, with 202.8 million people fully vaccinated and 56 million who have received a booster dose. We are doing really well in coverage. 72% of the US probably has booster doses, and 95% of our population over 65 has done well. But as you saw before, we really need to do a better job with our kids. 20% have received, 5 to 11-year-olds have received their first dose, and about 60% have received their first dose at 12 to 17 years of age. I just want to emphasize one other issue around vaccine safety and protection is that here on the bottom left, you see the number of cases. In the blue are the fully vaccinated, and the black are the unvaccinated. The risk of infection is almost 6 times higher if you're unvaccinated, and your risk of dying is 14 times higher if you're unvaccinated. And on the right, you see hospitalizations. Green is the vaccinated hospitalizations, and blue is the unvaccinated hospitalizations. And what that translates out to is adults 18 and older, COVID-19 hospitalization rates are 12 times higher in unvaccinated people, 14 times higher among those 18 to 49, 15 times higher among those 50 to 64, and 9 times higher among unvaccinated 65 years and older. So clearly, we are still being driven, unfortunately, by an unvaccinated population. So Omicron is critical, but vaccines for unvaccinated people are even more important. These are risk factors, and you can see for death, You can see that hypertension and diabetes are strong risk factors that tend to go up over age. Dementia goes up over age. Heart disease goes up over age, but lung disease and obesity are important across all age groups. So we have a wide number of populations at risk because of lung disease and obesity. So everybody should consider getting vaccinated. I'm just going to end with these last couple slides showing you that Pfizer and Moderna and J&J overview from a year ago. Vaccines, randomized controlled trials using COVID-19 symptoms with PCR positivity as the outcome in over 100,000 people for the 3 vaccines. And we saw basically 94 to 95% efficacy for the mRNA vaccines and 66% efficacy for the 1-dose J&J vaccine. Now, currently, only the Pfizer vaccine is available via FDA EUA for individuals under 18. It's available from 5 years and above. And today, Pfizer applied for full approval from the FDA for 12 to 15-year-olds. They already have full approval for 16 and above. So we'll see how quickly that is reviewed and shared with the rest of us. I want to remind everybody that immunity comes in all flavors. And we are aiming for primarily immunity against hospitalization and death. Obviously, we would like to see immunity against other stages such as symptomatic upper and lower respiratory infection and even sterilizing immunity, but that's going to be harder to achieve. But right now, we're still focusing on keeping people out of the hospital and keeping people from dying. And when we look at epidemiology of the disease in kids, we know that over 1.9 million cases have been reported in children 5 to 11 years of age, with over 8,300 hospitalizations as of mid-October, similar to what we see for pandemic flu or regular seasonal flu. And the severity is comparable to what we see with influenza. MISC, again, is most frequent among 5 to 11-year-olds, and we are seeing post-COVID conditions in children. Secondary transmission from young school-age children does occur in household and school settings. The impact on community-wide transmission is not huge. It's about 8%. So if kids 5 to 11 were vaccinated, we'd see probably an 8% reduction in community transmission. But it is important, but that is not the main reason to vaccinate kids. And here you see school closures just from August to October. Over 313 school districts across the country with 1.2 million kids affected. And you see the areas where these closures occurred were primarily in states with low vaccination rates. And then I'll end with these last 2 slides. These were studies that were done here at Stanford and other sites around the country, was published in the New England Journal a few weeks ago, looking at a randomized controlled trial of over 3,000 children who were vaccinated at a 2-to-1 ratio with either the Pfizer vaccine at a lower dose compared to placebo. And we see here up on the right, the Kaplan-Meier curve showing that over time, over the follow-up period, only 3 kids in the vaccine arm got infection and 16 children in the placebo arm were infected with a final vaccine efficacy estimate of just about 91%, with virtually no serious adverse events and none related to the vaccine itself. And I want to stop here. And this is just a picture of one of our patients who wanted us to share this with everybody in our clinic, in our vaccine clinic. This is my great clinic staff who have run this study here. We are actually enrolling more kids than any of the other sites in the US, so we're excited about that. And the mom of this little girl said she was more excited to find out that she'd been in the treatment arm than she had been when she found out she was pregnant with her little girl. So you can see how excited families are, and we want to make sure people understand that these are safe and effective interventions. So I'll stop there and hand it over to Grace.
Thanks, Bonnie. That was unbelievable overview in 25 minutes. I hope I can do the same. Some highlights from the ACIP work group. So Alan mentioned that I actually currently chair ACIP. Just before I took on chair of ACIP, I actually chaired the ACIP COVID-19 Vaccine Safety Technical Work Group, or VAST as we call it for short. Our goal has been to review, evaluate, and interpret all post-authorization or post-approval COVID-19 vaccine safety data. We actually convened the federal agencies, and they are actually sharing their information, and collaborating on these safety monitoring studies, or not studies, but surveillance. We try and advise on analysis, interpretation, and presentation of these vaccine safety data. And importantly, when we have concerns, we provide those updates in a timely fashion to the ACIP COVID-19 vaccines work group and the entire ACIP, which, as you know, happens in open and public meetings on COVID-19 vaccine safety. So this has been a snapshot of my last year, a year and a half. The COVID-19 VAST work group meetings, we started in June of 2020, had 14 meetings preparing for vaccine safety surveillance in the US and making sure we had this coordination across federal agencies. On December 21st was our first sort of post-authorization meeting. So Bonnie mentioned December 12th was our vote for the first doses of vaccines to be given in the US on December 14th. And within a week, we actually were already reviewing data. Since that time, we've had 45 meetings to review vaccine safety surveillance data with our federal colleagues. In addition, I sit on the COVID-19 work group, and that really looks closely at the data on benefit risk balance and the evidence to recommendations framework. And in 2021 alone, we've had 42 meetings. I lost count of 2020. And then for ACIP, since the pandemic began, we had 10 public meetings on COVID-19. And in 2021, we've had 13 public meetings on COVID-19, with the last being yesterday. So these were our meetings to date. And these are the decisions we've had on the left since the first vaccine was approved in December of 2020. What I show here are 11 decisions that we've had an open meeting or deliberated upon an open meeting. These are the ones that are very pediatric oriented. So in May, the Pfizer 12 to 15 was approved for use. August 13th, we voted on immunocompromised, including those who can receive Pfizer vaccine if you're 12 and older. And then November 2nd, we voted on the Pfizer 5 to 11 data that Bonnie just mentioned. And on the right-hand side here, what you see are the VAST assessments. So this is the Vaccine Safety Technical Working Group. And these are the public meetings that we presented at, or public updates we provided to the website to ensure that we're updating the public continuously on where we are with vaccine safety surveillance. And the topics are described here. So initially we were focused on anaphylaxis. We also are monitoring pregnancy vaccine safety. In April, you might all recall that there was a signal for TTS, or thrombosis with thrombocytopenia syndrome, and the Janssen vaccine was actually paused. We met, reviewed the benefit risk balance, and actually resumed vaccination at that time and continued to monitor it. In May was when we first learned about the myocarditis signal that was emerging from our vaccine safety surveillance systems. In June, we shared the information around Guillain-Barré syndrome following adenoviral vector vaccines. And here you can see we continue to provide updates, and more recently focused on the booster dosing. So next, I'll just highlight the vaccine safety monitoring systems that are available. We do tend to rely in terms of real-time data on what's on the left side here to drive a lot of the conversation, but just want to acknowledge that there has been really robust data shared by the FDA through their BEST initiative. The Department of Defense has been really outstanding as a partner, as well as our VA partners in terms of data sharing and making sure that we are all looking at the data together, as well as Indian Health Service. So it's been really a strong effort, and VSD really sort of belongs in this bucket. They really have been doing a ton of vaccine safety surveillance. These are the systems, again, that we rely on mostly for real-time surveillance and monitoring. vSafe is a smartphone-based system that allows people to report in any symptoms, typically mostly focused on local and systemic reactions, but there's also a pregnancy vSafe module that pregnant women can report into, and they're actually following women all throughout their pregnancy and after the birth of their child. VAERS is a passive reporting system, and if any of you have contacted me with vaccine safety issues, I've always encouraged people to report into VAERS, whether or not you think it's related, because this is our signal detection system. Anyone can report, including parents, family members, providers, patients themselves. So this has been really important for us for early detection, but it's not a great system for determining causality because it's really numerator-only data. The Vaccine Safety Data Link is incredible in terms of conducting real-time safety surveillance. So they're monitoring on a weekly basis all patients coming in who are vaccinated and all follow-up data in those populations. And we rely on them especially because not only can they detect signals, but they can also quickly evaluate signals, including through medical record review. And then our CISA team, and Dr. Kathy Edwards presented recently, but has been also a really important part of our vaccine safety surveillance system. They have enhanced their consultation service. They do consults nationally. Clinicians who are caring for patients with a possible adverse event, if it impacts their care or their further recommendations, I'm always encouraging individuals to consult CISA as well. And what I appreciate about that group is they actually do deep dives into the data, and they bring together a national network of clinician experts that are focused on a particular topic, whether it's neurologic adverse events or ophthalmologic adverse events or anaphylaxis as examples. So really, it's been an incredible and intensive effort over the past year and a half. Oh gosh, I'm so sorry. In terms of monitoring and responding to safety data, we have really focused in for the mRNA vaccines on anaphylaxis and myocarditis, as I mentioned. For the Janssen vaccines, the thrombosis with thrombocytopenia syndrome and Guillain-Barré syndrome. Additional pre-specified adverse events are always being monitored in the background, and then maternal immunization. And then we actually are incorporating these real-time safety data into real-time decision-making. And we are constantly reevaluating the dynamic benefit risk balance. And a lot of it depends on where we are in the pandemic as we understand new safety signals emerging, and also our ability to think about how to support risk mitigation strategies. And so a lot of, what we hope to do in bringing the data to ACIP and to the public transparently is to make sure that we can support informed discussions about the benefits and risks of available vaccines, and also ensure that we have sufficient clinical guidance to support early detection and appropriate management of potential adverse events. This actually, Dr. Maldonado already covered. At the time we were having the 5-11 vote in November, we recognized there were many cases, hospitalizations, and deaths occurring in this age group, and that COVID-19 is now vaccine preventable. This slide actually compares this to other vaccine preventable diseases, and you'll see that there are as a comparison, people are often comparing children to adults, and children don't get that sick. But in fact, we do a lot in our own pediatric practice to ensure that we are optimizing the health of all children. And in fact, we often don't say that, well, cancer is less common in children than adults, so it's not as important. We consider it as important, if not more important, as pediatricians. And so would just encourage people to, rethink that narrative and really focus in on what we can do for the pediatric population. And it turns out now COVID-19 for the 5 to 11-year-old population is the 8th leading cause of death in the US. In addition to the direct medical impacts, there's obviously the indirect impacts of the COVID-19 pandemic on children. And, again, this audience knows extremely well the impact on mental and emotional health, and anybody with children knows this actually. The widening of existing educational gaps that already existed for many children, other sort of health-related issues, increases in adverse childhood experiences, and loss of caregivers due to COVID. So we carefully considered the benefits and the risks, and the benefits are on the left, and Dr. Maldonado clearly articulated why we thought it was an important issue, but we also are always balancing that against potential risks, and myocarditis has been the concern that we were focused on, in particular for that vote. At that time, what was presented by our vaccine safety surveillance teams was this data, which describes VAERS adverse reporting event rates for myocarditis following mRNA vaccination in the 0 to 7 day risk window. And you can see here, as has been demonstrated before in other grand rounds, that the predominance of myocarditis cases is occurring in younger males. And not as frequently in females. So clearly here in this younger age group in this population. So then the question is, how does this myocarditis present? Matt Oster, Dr. Oster from CDC and Emory actually did a really wonderful job explaining this in the meeting, comparing classic myocarditis that we have all seen in our hospital, secondary to viral infections, to what we now know as, MIS-C-related myocarditis, COVID-19 related myocarditis, which is observed much more commonly in older adults. And then COVID-19 vaccine-related myocarditis. There is some overlap, but there are some differences. And we think that the phenotype looks very different. This was published out of his group at Emory and shows an example of time to normal injection fraction by echocardiogram. The blue here indicates vaccine-related, classic myocarditis, so viral associated myocarditis cases. And this is our clinical experience from before, compared to MISC, where we fortunately have significant disease, but often see significant recovery, and comparing that to vaccine-related myocarditis, which again, just seems to present very differently in that population. So much, the vast majority, fortunately, being mild and continues to be a rare adverse event, although more common after the second dose in males. And then I share this because I feel like you can't talk about vaccine safety without putting it in context. So there are many conditions here on the right associated with SARS-CoV-2 infection. This is actually focused more on an adult population, but you see acute kidney injury, arrhythmias, DVTs, myocardial infarction, intracranial hemorrhage, myocarditis and pericarditis, and pulmonary embolism are all extremely common following SARS-CoV-2 infection. And in fact, vaccination is protective in some instances for acute kidney injury, intracranial hemorrhage. But we do recognize that there are small risks associated with vaccine-associated myocarditis. As a consequence, we are fortunate that our CDC colleagues initiated a long-term surveillance study that we call the MOVING study for short. They are doing active outreach to patients less than 29 years, reported to have myocarditis, who have been reported into VAERS. And so again, continue to encourage all colleagues to continue to report into VAERS. They are doing surveys of patients and cardiologists at 3 and 6 months post-diagnosis. For patients, they're asking about symptoms and health status assessment as reported by patients. And for cardiologists, they're asking about cardiac follow-up and recovery status, including resumption of normal activity. Approximately half the eligible patients with sufficient follow-up time are reachable and willing to participate. Not everybody provides contact information in the VAERS database, and so they're not able to follow up with every single event. In addition, there are continued efforts to reach the patient's cardiologist for their medical status. I'm recognizing that all of us have been incredibly busy as clinicians, but for those cardiologists who might be listening out there, if somebody from the CDC calls, I'm hoping you'll pick up, because it will contribute to our understanding of the long-term consequences of COVID. About half of the eligible patients with follow-up are participating, but less than half of their cardiologists have been able to be contacted. I know CDC is continuing to renew efforts to do this, and we will provide updates at future ACIP meetings. I just also wanted to make a brief mention of what I think of as a really important thing we haven't talked a lot about, but post-acute sequelae of COVID-19 infection, or PASC. There has been much characterized in the literature about long haul COVID in the adult population, and some literature that is now emerging on pediatric population. But I think we still have a lot to learn about the impact. And I encourage us to really think about this with a pediatric lens in mind. In particular, children are often, they have a dynamic developmental background that, goes along with their age, whereas adults kind of are at a fixed status. And so a lot of things are a comparison to how they felt before, a comparison to normal. I think this is much more challenging in pediatrics, where kids are, their normal is constantly changing in terms of what is appropriate development. Being able to better characterize the long-term consequences of COVID-19 infection, I think, is not only important for those patients that develop these consequences, but also are important for our understanding of the preventability of this particular consequence of COVID-19 infection. So a whirlwind tour through our updates from yesterday's ACIP meeting, and focused on children 5 to 11 years. The vSafe system has been monitoring in children who have been reporting in, their parents have been reporting in on behalf of their children, and looking at, for example, any injection site reaction or any systemic reaction. And what you can see here is what you would anticipate. Injection site reactions are common after dose 1 and dose 2, and similarly, systemic reactions after dose 1 and dose 2, perhaps slightly more common after dose 2. Health impact being a general question, and inability to perform daily activities, fortunately not being too common. But of course, we always anticipate that sometimes side effects can knock folks out for a day. In terms of reports into VAERS, they have 3,000 reports in as of December 10th. There are approximately 7.1 million doses administered as of December 9th, and you can see there's 5 million dose ones and 2 million dose twos in this age group, about half male and half female. This just shows the reports by year of age, but nothing really significant to note there. These are the most frequent adverse events reported into VAERS. So incorrect dose administered, no adverse event, product preparation issue, and then the usual sort of vomiting, fever, syncope, dizziness. So the common sort of post-vaccine symptoms you would anticipate. Those being the most common. In terms of the update on myocarditis, among those reports to VAERS and among children 5 to 11 years of age, there were 14 reports of myocarditis. There are actually still following up on some of those cases to confirm that they meet criteria for myocarditis, the CDC criteria. There are 9 reports with follow-up information obtained, and 8 of those 9 reports met the CDC working case definition for myocarditis. Half in males and half in females, and mostly after dose 2. They actually shared the characteristics. It looks very similar to what we have seen before in the adolescent population. It is too early to provide estimates on what these rates will look like. You can do the back of the envelope calculations, but we are still in process of understanding the data. The cases are continuing to be reviewed, and at least in the 6 reports with known outcomes, 5 of the 6 were fully recovered already from symptoms. And then finally, an update just briefly, because I just wanted the audience to be aware that yesterday we discussed safety data around the Janssen vaccine at the ACIP meeting yesterday. And after the meeting, there was a vote, and it was a 15-0 vote, that ACIP recommends that mRNA vaccines are preferred over the Janssen or Johnson & Johnson COVID-19 vaccine for the prevention of COVID-19 for all individuals 18 years of age and older. And this was really due to data that emerged. We actually learned about it last Monday at the VAST meeting, took it to our COVID vaccines work group last Thursday, and then had the open meeting yesterday to bring it to the public, focusing in on the TTS data. There was additional follow-up on those cases and a recognition from my perspective that although risk mitigation measures have been put into place, it is really challenging to do 2 things. Number one, to ensure that there is equity and access to the information needed about the benefits and risks of all vaccines, and that there is choice in the US. And second, that there is, even despite early identification and appropriate clinical management, some of those cases, in my mind, were not preventable, and hence this strong preference for mRNA vaccines for adults going forward. So looking ahead, some of you have asked these questions, and I am anticipating these are some of the things that we will address, but things I've already been asked. Should immunocompromised children 5 to 11 years of age receive an additional dose? Will boosters be needed for children 5 to 11 and 12 to 15? How will we ensure that children are optimally protected in the safest possible manner? That is an ongoing discussion always. Will protection for children be durable? And when will we have a vaccine available for children under 5? I anticipate ACIP will continue to deliberate on these issues as the FDA EUAs come through, and we will certainly bring this to the public through our ACIP meetings. I anticipate many more emergency meetings for 2022. So thank you all for your attention, and happy to take any questions.
Incredible. Thank you both so much. And predictably, there are numerous questions. Thank you for answering some of those. If folks look at the Q&A tab, there's an answered section that you can read through, and some of your questions that weren't answered in the talk may be answered there. I'm going to start, actually, I'm going to try to choose ones people have been liking various questions. And so I'll try to, since I don't think we're going to be able to get through all of these, I'll try to start with some of the ones that have been popular, so to speak. So David Lewis asks about concerns about Omicron being more prevalent and asymptomatic spread. And really, what are we going to do, if anything, about changing PPE and the types of masks that we are wearing? Both, he asked about the outpatient side, but I assume people on the inpatient side have similar questions.
Yeah, that's a great question. I don't know that we're quite there yet. Yeah, I do feel like some people are more interested now, for example, in wearing KN95s or not wearing cloth masks. I just want people to wear masks. I'm right now in Texas, and you would think there's no pandemic here. So I think what I'm really worried about is that people are really tired of this pandemic. I'm tired of it. Grace is tired of it. But when you're around a lot of other people, this virus is really, it's a cold virus. It's a very transmissible cold virus, but with potentially a 1% mortality rate. You don't want to be that 1%. You saw the risk factors. So I just think getting people to wear a mask. Now, in the hospital setting, we'll have to evaluate that. We're not seeing anything yet from data around the world. And that's where we're interested in looking at our South African healthcare worker colleagues to see if they're having breakthroughs even with good PPE. But I just think we've done a pretty good job with our N95s, et cetera. So we're not quite ready yet to make any changes, but that could change. If this virus, the virus is more infectious, but I think the current methodology is still pretty good. We haven't looked at viral load yet, so that might dictate something, but we know viral load is pretty high already anyway at the beginning of infection. So I would just re-emphasize what we're doing now and be currently careful, because I think we've slipped a little about, oh, let me not, gel, or, if I'm out at a restaurant or something, I would just make sure we just stick to the basics again and remember what we were doing before we had vaccines.
Great. Some interest in a question about whether healthcare workers, especially seniors, should get a fourth shot if they got their third shot in August, and asking about getting Moderna if their first 3 shots were Pfizer or vice versa.
Well, I'll emphasize the key points, which are that I would really emphasize getting a booster. If you hadn't gotten your booster already, I think it's really important. With Omicron here, it's totally clear that we are all at risk for infection. We always have been, but I think the risk is increased over the next month, and particularly even in our local Bay Area, and especially with the holiday travel. I think that's probably the most important thing. I often get questions about, like, is there a better sequence? Is there a better, should we be getting additional doses? I am very much anticipating this question will come up very soon to ACIP. The current recommendation does not actually state a fourth dose at this point, other than for those who are immunocompromised, for 3 doses considered the primary series, and then there's a boost after that. But as the data evolves, as the pandemic evolves, I anticipate we will be constantly weighing 2 things. One is where we are in the pandemic and how much burden there is, while also making sure we balance that against concerns about safety. And I think that's sort of, if we didn't worry about vaccine safety, it would be an easy answer probably for everybody. And I think we feel the responsibility of making sure that as we make these recommendations, we are balancing both the benefits and the risks. And we are trying to be as timely and transparent as possible. Omicron might outpace us all. So I guess we're just gonna have to see how the next few weeks go.
In terms of thinking about travel and seeing families and risk mitigation, several questions about testing. What are your recommendations about home testing, when to do it? Are they good? Are they reliable? Those sorts of questions.
Yeah, I have really strong feelings about that. I think that's one of the biggest mistakes we made a year ago. There were very good epidemiologic data that testing on a regular basis with a cheap, affordable, maybe not a PCR test, but just any good test would really reduce the amount of people infected in circulation. So I actually think it's a really good idea to test. So here's the thinking. You're gonna bring people together from different parts of the country or state or whatever. Get a test. They're easy to do. You might have to buy the Binax if you can find them, but get a test. Test yourselves into your pod and then stay with your pod. You're going to be safe. And so I would recommend that, especially if you have kids under 5 who can't be vaccinated, if you have people who are immunocompromised or elderly who might have underlying conditions. And by the way, we didn't have a chance to talk about treatments, but AAP is coming out with a really nice document. It should be coming out hopefully next week on monoclonal antibodies. Just emphasize that it's not the go-to thing. It's only for the highest risk people. It's not easy to do monoclonals. We did the monoclonal studies here at Stanford, and they're a real pain. It's not easy. The scheduling is tough. It's 3 hours. So there are treatment monoclonals, there's pre-exposure and there's post-exposure. And unfortunately, what we're seeing with Omicron is that 2 of the 3 monoclonals look like they don't work. So I wouldn't depend on monoclonals at this point, but if somebody is really sick, whether they're vaccinated or not and got infected, if they're sick, there are still monoclonal opportunities for people. I just wanted to bring that up because I know it came up, but we're seeing that monoclones, only one of the monoclones may actually work right now. Well, for Delta, they should work, but that should be a last choice and not in exchange for vaccination.
Yeah, and I just want to emphasize that, like, I know that the communication has relied a lot on vaccines. As Bonnie said, masking is critical, and testing, I think, is incredibly critical and has been undervalued as a really important strategy for the country. My personal story is that when I get together with my family, before we get together, we all just rapid test before we meet to make sure that we're all negative. And I just would say use common sense. Fortunately, testing is accessible to us. It's not accessible to everybody, I think, is the challenge. And how do we make that accessible to anyone who wants to test? If we make it hard, people aren't going to test and transmission will continue to happen.
There's another question here about testing, but just to follow quickly on Bonnie's point about monoclonal antibodies, to confirm, Paul Grimm asks if you will be helping with guidance and procedures around pre-exposure prophylaxis. I'm assuming the answer to that is yes.
It already exists.
Yeah. And then David Lewis asked a question about, I assume this implies to sort of what we're learning about the Omicron virus and the patterns, but asked if we have the dual PCR looking at both the spike and the N protein for here at Stanford. Is that something that we will start testing?
Yeah, Stanford already has that capacity. They don't look at just one gene. So we obviously, if you only look at the S gene drop, you're going to miss it because Omicron is an S gene dropout, or SGTF, whatever it's called, target failure. But we target 3 different epitopes on the genome, so we'll pick it up, and all of them are being sequenced right now anyway at Stanford. So we'll find it if it's there.
Okay, well, I think just for the sake of time, sorry we weren't able to get to all of our questions. We're a minute over. Thank you again for being so involved in this and for keeping us up to speed on what has been such a challenging couple of years.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.